Good afternoon, everyone. My name is Deanna Fenton, Program Manager here at the Alliance, and I'd like to welcome you to today's webinar, The Littlest Donors, Honoring the Gift of Life Through Neonatal Donation. We are so pleased that you could all join us today as we have a wonderful presentation in store for you. Now, before we begin today's presentation, there are just a few logistical items that I'd like to review. For optimal visual and audio experience, we do recommend accessing these webinars in the Chrome browser. So if at any point you encounter any audio issues, we do recommend logging back in using Chrome. If you continue to experience any issues, please dial in using the phone number provided in your confirmation email. Now, for those of you who have never joined us on this webinar platform before, please take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat can be used to pose any of your questions to our speakers. So if you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Now, in regard to our upcoming webinars, please note that registration is currently open for our next webinar, Overcoming the Challenge of Timely Declaration of Brain Death. That's coming your way on August 13th at 2 p.m. Eastern. Registration is also open for our upcoming transplant webinar, Protect the Skin You're In, Early Detection and Prevention of Skin Cancer. Be sure to join us for that on August 27th at 3 p.m. Eastern. You can register for all of these webinars and more on our website at organdonationalliance.org. For anyone seeking continuing education credits, please note we are offering one CET-C credit and one nursing contact hour for this webinar. Everyone joining us today is entitled to claim any of these credits. If you're listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. Please note there is a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing you'll have 14 calendar days to claim your credits, and for CEP-C you'll have 30 calendar days. Now at this point in time, I'd like to introduce our moderator, Rachel Gibson, Donation System Specialist at LifeGift. Rachel, thank you so much for joining us today. At this point, I'd like to turn it over to you to introduce our speakers.
Great, thank you so much, Deanna. Good afternoon, everybody. I just want to thank the Alliance for having us on today to talk about this topic for our webinar. I'm first going to introduce Schawnte Williams-Taylor. Schawnte is the Director of Family Care at LifeGift and also serves as an administrator on call and an approach coach, helping to provide oversight in our daily organ operations. Schawnte is a graduate of Western Governors University, where she's obtained a Master's in Science Management and Leadership, and she is also currently enrolled there for her MBA. Schawnte has also obtained her Bachelor's of Science in Nursing from the University of Texas Science Center, Houston School of Nursing. Prior to her role as a Director of Family Care, Schawnte served as the Director of Clinical Operations for the Southeast region and the Managing Director of the West region of LifeGift DSA. Schawnte joined the LifeGift family in 1999 as a Donation Clinical Specialist and in-house coordinator for Ben Taub and Memorial Hermann Hospital. During her time here at LifeGift, Schawnte has participated and assisted in the Organ Donation and Breakthrough Collaborative with the Department of Health and Human Services. She has co-authored in several editions of the Critical Care Nursing on Donation and Transplantation, as well as many posters presented at AOPO and NACCO. She has also been a national speaker for AOPO and served on the planning committee for the Texas Transplantation Society's annual meeting. Schawnte has also served on the board of directors at AMS. Our second presenter we have today will be Dr. Karen Johnson. Dr. Johnson serves as the Associate Dean of Admissions at Baylor College of Medicine, as well as being a neonatal attending at Texas Children's Hospital Newborn Center. Dr. Johnson is an Associate Professor of Pediatrics and a faculty member in the section of Neonatology for over 20 years. She has received her Bachelor's of Science from Xavier University in Louisiana and attended Baylor College of Medicine. Dr. Johnson continued her postdoctoral training at Baylor, in both completing her residency and fellowship training. She is board certified in neonatal perinatal medicine and palliative care and completed the Baylor College of Medicine, University of Texas Medical Branch Educational Scholars Fellowship Program for teaching and curriculum development. Dr. Johnson has also appeared on Houston's KHOU Channel 11 for over 10 years as the medical correspondent for the Focus on Health television segments. Dr. Johnson's primary clinical responsibilities are seeing patients and program director of the Perinatal Pediatric Advanced Care Team, otherwise known as PPACT, at the Texas Children's Hospital's Newborn Center. As a PACT coordinator, Dr. Johnson leads a multidisciplinary team that is able to provide comfort and care to patients and families living with a life-threatening, severely advanced chronic illness. Dr. Johnson is committed to improving the quality of life for patients and chronic or life-threatening illnesses and ensuring the future of healthcare by teaching and mentoring the next generation of medical professionals. Thank you both, Schawnte and Karen, for being with us today. And with that, Schawnte, I will turn it over to you.
Thank you, Rachel. And thank you all for this opportunity to speak with you on today on a topic that's very important and focusing on the littlest donors and honoring the gift of life through neonatal donation. So LifeGift is a federally designated not-for-profit organ procurement organization and one of 58 OPOs in the country, one of 3 in the state of Texas. And as you can see, our geography is spread throughout the state, and we serve over 200 hospitals in 109 counties here in the state. So just to touch briefly on our objectives and focusing on the process of identifying and evaluating neonatal donation opportunities for families, and what are the best practices for collaborations between the OPO and hospital partners for neonatal donation, and also to speak a little bit about the impact of this opportunity for donation for families and the communications in which we serve. I want to focus on this unique opportunity that we do have, and based on the study that I came across in 2015 that really spoke about some of the gaps that we have and face in this population for donation and the opportunity for OPOs and hospitals to collaborate and establish plans for organ tissue and eye donation in the neonate population. Even prior studies have identified those gaps of potential donors in terms of timely referral to the organ procurement organization, as well as the education for NICU practitioners and staff regarding the process for the referral to the OPO, and even the thoughts that is there really an opportunity for donation in this population of patients. Currently here in the country, we have slightly over 100 pediatric patients awaiting a life-saving gift, each under the age of 1 year. And so there is an opportunity for us to collaborate and look at where are the opportunities to bridge the gap. So it really begins with the establishment of clinical triggers for the referral to the OPO, and it provides an opportunity for the organ procurement organization to come on site and for timely evaluation and assessment of suitability of the patients who may potentially be candidates for organ tissue and eye donation based on the specific criteria as noted. The criteria, whether it's for brain death or it's for donation after circulatory determination of death, or it's possibly for tissue donation after cardiac death has been reached. It's the opportunity as the hospital provides that notification to the organ procurement organization within 1 hour of the patient meeting these triggers. So per the CMS requirements, hospitals receiving Medicare funding should have an agreement with an organ procurement organization, the tissue bank, and an eye bank in which all deaths are reported to the OPO. All deaths, as I mentioned previously, reported in a timely manner, and for imminent deaths, those are potential candidates for organ donation should be reported within that time frame. And again, going back to focusing on a timely on-site response or evaluation via phone so that we're able to preserve the opportunity for donation, and when it's appropriate to move forward with having a discussion with families about that opportunity for donation. And it further requires that individuals approaching families have been trained by the organ procurement organization, and designated requesters are approaching families with sensitivity and compassion. So it all really begins with that initial referral to saving lives. And typically and traditionally, the referrals are originating from the hospital. Where the referral is made, there is the evaluation. And then there's the on-site piece where there's a collaboration with the OPO and the patient care team, huddling to identify what are the opportunities for donation. Is there potential for the patient to even become an organ tissue or eye donor? Oftentimes the calls may originate from the OB/GYN's office or neonatologist's office prior to delivery, as parents may express interest in knowing what are their options for donation? Early linkage to the OPO does provide an opportunity for evaluation, huddling, and planning for the discussion with the family. If the family's decision is to move forward with donation, there's even greater opportunity for this collaboration between the organ procurement organization and hospital partners to optimize the opportunity for organ tissue transplant. So it's really important in preparing for having conversations with families to manage expectations, being really realistic based on the information that we're able to obtain on the baby's condition, about potential donation opportunities, being very transparent about this rare opportunity and providing compassionate, honest communication with the parents as well as our hospital partners about the possibility for donation, and also realizing that donation donation may not always be the outcome where organs are transplanted or recovered for research. The true gift is in the decision of families' desire to help others. Again, it's vitally important to share information, provide resources for neonatal donation, as well as provide continued support for families that are experiencing this situation in which they know that their child will not be going home with them. So ongoing support is also important. I'd like to share with you a few stories in terms of how hope can potentially be offered in situations in the midst of a tragic diagnosis in which families are told that their child will not be coming home with them. Imagine working for the OPO and you receive a phone call from a family, specifically the mother who's just left her physician's office, and she's been given this terminal diagnosis that her child is anencephalic and that her child's chance of survival will not happen because of this devastating congenital disease process. And the options that she's given at that point in time is that she can make the decision to terminate the pregnancy or make a decision to carry to term, realizing that there's a high probability that her child will be born stillborn, or that hours to a few days after birth that her child will not survive and death will ensue. Another situation, receiving the phone call from a mother who is at a time of making a crucial decision in whether to continue the pregnancy because her focus and her goal, because she's seen a story in social media about a family who is in a similar situation as hers in which her child is not going to survive, being given the opportunity to donate their child's organs and looking for a guarantee from the OPO that her child's organs can be used for transplant, and her coming to the realization that it's not guaranteed, so she has to make that difficult decision, which is best for she and her family to move forward with terminating the pregnancy. So there is an opportunity in these devastating times with these families to be able to see how, as OPOs and healthcare practitioners, there is a potential opportunity to offer hope through the gift of donation. In situations where it's before the child is born, or even if we have the situation where there is a child in the neonatal intensive care unit who suffered a devastating injury during birth or after birth, requiring supportive medical therapies, which require mechanical ventilation. And at this point, the healthcare team, in collaboration with the family, makes the decision to withdraw life-sustaining therapies, and there is the potential for this child to potentially donate organs. The grief and the sense of loss experienced by these families, unanswered questions, questioning their faith, and trying to understand why this is happening to them is definitely evident. So as a team working to provide the support and understanding, as well as providing all of the information about potential opportunities to families, it's really important that there is a collaboration. So what are the opportunities for donation for these families? For patients that are in the NICU, potentially where there's the opportunity for donation after neurological death neurological determination of death, potentially an opportunity to donate organs for transplant, with the greatest need being in the area of heart and liver transplant currently. There are challenges in which Dr. Johnson will address in her presentation surrounding the declaration of death in this population of patients. What we often see is the opportunity for donation after circulatory determination of death, in which in-block kidneys have been recovered and transplanted into adult recipients. And in these situations, patients are ventilated, and upon an allotted time in which their heart may stop, we're able to potentially proceed with the recovery of these gifts for transplantation. In a study conducted by Harvard, it showed that only 8% of deaths in the NICU were suitable candidates for DCDD. There are opportunities for the gift of tissue donation for the heart-for-heart valves and cartilage in situations where the patient has reached cardiac death. Further opportunities for families is the opportunity for neonatal gifts donated for the purpose of research. In the experience with the International Institute of Advancement of Medicine, it demonstrates that 59% of the babies giving the gift of donation for research have a diagnosis anencephaly, 20% from anoxia, and 21% from other gestational developmental anomalies such as spina bifida and countless others. In addition to these gifts, there is an opportunity for families to donate whole body after the recovery of these gifts for ongoing research and even for transplantation. One of the key indications that has been identified is that in addition to use of these gifts listed, researchers are observing organs and utilizing organs and cells to develop in many ways for the advancement of medicine and medical therapies to stop or to better manage disease processes. Certain criteria for any of the types of donations that may be offered to these families after further evaluation based on specific criteria and the age of the baby, the size of the baby, as well as the clinical presentation will lead to determine which gifts the family is able to move forward with offering donation. So, decisions to move forward with donation are often family-driven, so it's really important that there's strong, powerful partnerships between hospitals and OPOs, each of whom have a mutually exclusive goal of taking care of the family in a sensitive and supportive manner. Some of the key areas in the approach in working with these families with such a devastating diagnosis is having a team approach, multidisciplinary in nature, to best support this family, especially in situations and clearly understanding what does the family desire for their baby in this situation. What are their goals? What are their hopes? And what are the resources needed to best support this family? Understanding the family's birthing plan, so there's no disruption in the plan when the baby will be a donor, and that is the hopes of the family. It is important that there is trust and connection with the family as well as the OPO and the healthcare team with effective communication, clearly defined processes, and the clarity of roles in supporting this family. A key thing that all parties need to be aware of is what are the policies that are in place for hospitals to support the various pathways for donation for these families, and ensuring that hospital and OPO staff have been trained to these processes so that it is a seamless process for the family and it's a meaningful process for all that are involved in honoring the hopes of these families. Clear information on what is the birthing plan for this situation with this family. Upon the birth of the baby, are there plans for moving forward with administering life-sustaining therapies such as mechanical ventilation should the baby meet weight requirements for DCDD? Or if the baby's already in the NICU, Is there a plan for withdrawal of life-sustaining therapies, and is the baby a candidate for DCDD? And if so, what are the plans? What are the steps? What is required by the hospital staff? What are the requirements by the OPO? And in collaboration with the family, the team begins working on a plan. It's comprised of, again, the hospital staff and the OPO staff with a walkthrough of the processes so that we can move forward with honoring decisions of this family in hopes to honor their wishes of their child being able to give the gift of life. It's important that the team comes together and works through the processes. And the team consists of the healthcare team, which may involve your neonatologist, your L&D staff, the nurses, the social workers, chaplains, palliative care, as well as OR and hospital administration, involving the OPO and those responsible for the education and training in the hospital setting, our clinical coordinators, family support staff, and the recovery teams consisting of organ and tissue recovery staff coming together to create a meaningful experience for the family, but again, ensuring that everyone involved in this process, in the care of the baby and of the family, has a clear understanding on how we can best move forward with the process of neonatal donation with an overall focus of the meaningful experience. Again, for a family who had the hope that they would be planning the hopes and dreams of taking a baby home and watching this child grow and experience the normal things that happen in the life of a child as they progress to adulthood, how can we come together to create this meaningful experience and be a part of this family's journey in creating a lasting legacy for their child? And to share and speak about experiences for these families, as you can see in the picture, Hannah Grace gave the gift of double lungs and liver and blocked kidneys for research, and the experience that her family had in being able to move forward and know that she made a difference. Or meaningful experience as in baby Liam's families, in which he did lose fetal heart tones. However, he was still able to give the gift of pancreas for research. And the joy for this family in knowing that he also made a difference, and it created meaning and purpose for this family in knowing of his role that he played in advancing diabetes research. Further meaningful experience experienced by the family and the parents of Maverick, who advocated for donation and changed policies in the hospital in which they were going to be delivering baby Maverick, and he didn't move forward with being an organ, tissue, or eye donor. However, Maverick created a movement in raising awareness for neonatal donation, and the parents continue for moving forward and creating awareness about the opportunities for families who may have been given the information about the only thing and the only choice that they had was to move forward with terminating the pregnancy. So the littlest of donors can have the lasting impact, and for these families, it is creating hope for leaving a legacy for their child, hope for other families that may not have to suffer the pain that they suffer and the loss of a child, and the healing for a family on their grief journey, creating purpose and meaning through this gift of potential for donation, as well as creating a legacy and allowing ceremonies and opportunities to remember their child, their life, the legacy, and although the life may be short-lived, the long-lasting impact of the gift that their child has given. And also for those that have the opportunity to go on and save lives through the gift of organ and tissue transplants, or for that enhancement of new therapies for medical conditions and the advancement of medical treatment and potentially cures for disease, the lifelong impact of the gift. And ultimately realizing the value for these families is not in the outcome, but it really is in their decision to give the gift to help others, and their generosity in the midst of their grief and knowing that their child is not going home with them, that they thought of others and willing to help. it really speaks to the generosity of families and the selflessness of these individuals and being willing to give that gift and to not think in terms of their loss, but utilizing and that energy and that power that they have to give and to help others creates that meaning and purpose for the short-lived life of their child. And with that, we will transition to Dr. Johnson.
Thank you, Schawnte. Very informative, colleague, and I'm so thrilled to be a part of this webinar today. And I hope to speak to you, colleagues, as a person who comes to you with the lens of a practicing neonatologist, who for my 28 years in neonatology have taken care of the most critically ill population here at Texas Children's Hospital, Baylor College of Medicine, and is an accidental palliative care physician, in that in the last few years I learned that end-of-life issues, including organ tissue donation in this population, is something that I needed more formal training so that we can be better partner and better stewards as it relates to this very unique population and how organ tissue donation is a consideration. So for the littlest donors today, as we honor the gift of life through neonatal donation, we'll move forward. So I thought I would begin. Of course, for this webinar today, we're looking at the neonatal population. We're looking at the fact that it's a very unique patient population as we consider organ and tissue donation. So I thought I'd begin by just, for especially those of you who don't practice neonatal care, give you a little idea about the patient population as a whole, looking at the numbers. And just as we look at the Center for Vital Statistics, in case you are not aware, but each year in the United States, anywhere from 3.8 to 4 million children are born. These are live-born children who generate a birth certificate. And looking at the 2017 statistics, as you see on the slide, in that year there were about 14,000 neonatal deaths. And colleagues, I hope you'll underscore neonatal as well, and that's why I put the definition. We're talking about 14,000 children who died in the first 28 days of life. Again, there are some unique considerations in organ and tissue donation as it relates to the neonatal population, and some of that has to do with, again, the timing of their birth and their death, and a lot of the characteristics that have surrounded the pregnancy. So a little bit about the patient population in terms of the numbers. And just to tell you a little bit about my world here at Texas Children's Hospital and the Texas Medical Center, and we are an academic center, Baylor College of Medicine affiliated hospital. So we have, as a corollary to that, many trainees across the full arc of training. And I do think that that is an important consideration, depending on the hospital that you work in. And depending on the staffing of that hospital, also has an impact on recognizing, embracing, being good stewards of the neonate as it relates to considering them as an organ donor. So here at Texas Children's Hospital, an academically affiliated children's hospital, we have high acuity and high census in our neonatal intensive care unit. Our neonatal intensive care unit has the highest criteria for taking care of the sickest, and that's what a level 4 NICU is. So our newborn center consists of levels 2, 3, and 4. Level 4 means that we have children who are on ECMO, children born with serious cardiac defects who need cardiovascular surgery imminently at birth. We take care of children who have had profound anoxia and require therapeutic hypothermia and cooling. So we take care of the sickest of the sick when it comes to the newly born. We also have a fetal center here. This center, a very robust center, which we've had for about a decade. Many of the mothers who are referred to the fetal center for fetal evaluation, it begins as a pregnancy that is now recognized as high risk because of typically a fetal ultrasound which revealed fetal anomalies, fetal abnormalities, birth defects. So these mothers are referred to the fetal center for further fetal evaluation, which could consist of fetal MRIs, fetal echocardiograms, genetic studies such as amniocentesis, because in recognizing the fetal abnormalities, we now will evaluate this pregnancy to determine what is the fetal diagnosis. In knowing the diagnosis, we can then counsel the family based on what we think the prognosis is to help plan. So we have a very robust fetal center. Again, the patient population is very high risk. The fetal diagnoses, prognoses, we'll get into that in the next few slides. We also have here at Texas Children's Hospital our birth pavilion. The pavilion for women is where the mothers will deliver. So however the mother is referred to the fetal center, some of these mothers come from outside of the major Houston metropolitan area. And after the fetal evaluation and diagnosis, some of them will return to their home communities to deliver their children, but many of them will continue to be cared for at Texas Children's Hospital in the pavilion, thus they will deliver their children here. And an important part of the pavilion and the mother-baby unit, which is where the mother is recovering from the birth, if the parents, based on fetal diagnosis and prognosis, have chosen a plan of care that is palliative in nature, is hospice care, then those children will stay with their mothers in the mother-baby unit and receive end-of-life care in the mother-baby unit. And then we have quite a busy cardiac intensive care unit. Many of the mothers refer to the fetal center. The fetal diagnosis will ultimately be one that is of a cardiac heart defect like hypoplastic left heart syndrome and other very complex cardiac lesions like heterotaxy syndrome, etc. So as we look at the big picture, yes, 14,000 newborns die in the first month of life. Here at Texas Children's Hospital, we have a quaternary tertiary medical center where our neonatal intensive care unit takes care of the sickest of children, but we also have a portal whereby children will come to our ICUs through the fetal center, and some of our children with life-limiting diagnoses will be cared for at the end of their lives in our mother-baby unit. And for those children who are diagnosed with complex congenital heart disease, they can be cared for in the cardiac ICU, but for those parents, again, who choose comfort care only, their care may only be in the mother-baby unit. So that's just a snapshot, colleagues, of the work here at Texas Children's Hospital. We have many levels of care providers. For those patients who are admitted to the neonatal intensive care unit, it begins with their primary team, which consists of course physicians and nurse practitioners and PharmDs and respiratory therapists. And each child in the NICU is assigned a social worker. And we also have as a member of our team our CCLS members, Certified Child Life Specialists. So that's the primary NICU team for each patient. And of course, we have every subspecialist that can provide care to the critical ill population that we serve. As a hospital, we have an identifiable formal palliative care service here, which has been in place for about 2 or 3 years. Our division chief, Dr. Tammy Tang, has developed a palliative care service that is responsive to the needs of the NICU 24 hours a day, and they have become very important partners with us in the NICU as it relates to discussing diagnoses, prognoses, and planning with families for the death of their child, and then part of that planning is considering the child for organ or tissue donation. And we also have a very accessible ethics consulting service if needed. And for those of you who don't take care of the newly born, just to tell you some of the common diagnoses that we see in the neonatal intensive care unit, prematurity, and prematures are defined as children born before the 37th week of the pregnancy. And of course, that means that in our intensive care units, we have children who are born at 23 weeks gestational age, 33 weeks gestational age, and 40 weeks gestational age. So for those children born before 37 weeks, they are considered premature. And that does affect, if you will, the patient's qualifications for organ or tissue donation. And depending on the OPO that you work with, there may be some very strict criteria about the gestational age of the child as it relates to their ability to be a potential donor. So here at TCH, we have every gestational age of children born in our intensive care units that we're caring for. Another common diagnosis in the neonatal intensive care unit are infections. Group B strep being one of the most common, which can be very severe, life-threatening, causing meningitis. A population of patients that, again, organ tissue donation is a conversation and a discussion that will be typically a part of the NICU journey. Children with a diagnosis of hypoxic ischemic encephalopathy. These are usually term children, meaning they were born after 37 weeks. The majority of them do not have birth defects. Their organs have been normally formed. However, this child has sustained severe hypoxic or anoxic brain injury, and because of that, are neurologically devastated, and albeit on life support while we determine the severity of their brain injury, whether the injury will be reversible or irreversible, this is a patient population where families are very invested in and very much so want to discuss organ tissue donation. And these are very, in my opinion, highly potential donors because, again, they're term babies and their end organs are normally developed. And then a very large cohort of patients that we take care of are babies who are born with congenital anomalies, birth defects, some of the syndromes that you are aware of, like trisomy 18, children with trisomy 18, which is a chromosomal problem, but those children typically have severe end organ birth defects as a corollary to it. So just in terms of the kinds of diagnoses we see in the neonatal intensive care unit, which again leads to patients who are potential organ and tissue donors. For those of you who don't do neonatal medicine, these are some of the common diagnoses. So when we look big picture, in terms of what are the 10 leading causes of death in the newborn period, meaning the first 28 days. I know you guys have now gotten into that language. The neonatal period is considered the first 28 days of life, and that's why I address how many children will die. I mentioned the 14,000 who will die in those first 28 days. So when we look at what are the causes of death in the first 28 days of the life of a newborn, number one is going to be those congenital malformations like anencephaly or hypoplastic left heart syndrome, chromosomal anomalies like trisomy 13, trisomy 18. The second leading cause of neonatal death, it has to do with prematurity, being born too soon, being very small. These issues as well are unique considerations as it relates to the neonate being a potential organ or tissue donor. Because if the child is born too soon or very premature at 25 weeks, for example, would they potentially qualify to donate an organ or a tissue? Well, that's why we have our OPO partnership with Life Gift, because a parent, a family, trying to make meaning and sense out of the life of this child who was born too soon, are grateful to know what opportunities are there to have a lasting legacy for their 25-weeker, even if the child will lose their life from being born too soon. And then as you can see, the third most common cause of neonatal death has to do with mommy complications. So mothers, some of them are quite high risk. Mothers will become pregnant when they themselves are status post a heart transplant or a kidney transplant, but choose to family plan and to have a natural pregnancy. So the children born to mothers who have serious medical conditions, those children as well may be born with medical conditions that will cause them to require intensive care. So this is just a picture, just to give you a picture of what it might look like to be an intensive care unit. You see the child to the left of the slide, which is a premature baby. To the upper right is a child on ECMO. And then the schema in the right lower, just one of the birth defects, abdominal wall defects that we see often. So one, again, colleagues, of the unique challenges as it relates to considering the neonate as an organ donor is that many times these considerations are done in the face of a patient population that is either extremely premature or has multiple birth defects or is critically ill requiring life support and has multi-organ system failure. However, we still want to consider, if possible, is this child at the time of their death a potential organ or tissue donor? So in the 21st century, whether it's in Houston, Texas, in the United States as a whole, or around the world, the most common neonatal death these days is because care has been withdrawn. Critical care, intensive care has been withdrawn, and there's now a redirection of that child's care from intensive, life-sustaining, life-prolonging to palliative care, meaning the focus will be on comfort and not escalating support. So the donation after circulatory determination of death is the one that is most commonly broached in this population, because as we withdraw life support, then the child is comforted and cared for to ensure there's no suffering until there is cessation of breathing and the heart stops beating and the child is now pronounced dead. And if the family has opted for organ or tissue donation after death has been determined, then this is where we then begin to work with our OPOs. The fact that there is more redirection or withdrawal of life support as the cause of death in these children, I think this is, for me, an opportunity to say that we can do a better job because these deaths, even though we can't predict the exact time of death, if there is a plan of care to withdraw support, then that means we can all be on alert so that at the time that the child is pronounced dead, we can move forward with organ donation in the most expedient way to idealize this organ donation. The determination of death is, as we think about in all of organ and tissue donation, there's donation after circulatory determination of death, which I've just alluded to, and then of course there's donation after neurological determination of death, which is a little bit more difficult in the newborn population. Again, a unique consideration in this population. There's a lot of ethical controversy around organ donation after circulatory death, and our governing organization, the American Academy of Pediatrics, we have a bioethics committee, and each year they review our policies, which are considered our standards of care, the gold standard. And as you can see, just based on current AAP policies, there are controversies as it relates to organ donation after circulatory death. There are ethical considerations that affect anencephalic patients being organ donors, and the American Academy of Pediatrics continues to look at societal trends as it relates to organ donation, whether it be after circulatory death or after neurologic determination of death. So there can be guidance for those of us who are neonatal providers as it relates to what is the best practice when we uniquely look at the neonate as a possible organ or tissue donor. Of course, one of the conundrums in the neonatal population are that some of the birth defects, which Some will use the term are lethal, meaning the child will not survive. Anencephaly is the example that comes to mind most often. This is a severe defect of the brain where most of the brain is absent, did not develop. The part of the brain that has developed is the brain stem, so many of the patients who have anencephaly will be born, if alive, they will breathe on their own. So anencephalic infants, over many decades, there have been ethical concerns as it relates to them being appropriate organ and tissue donors because of what we all know, the dead donors rule, which ethically says that the removal of viable organs should not cause the death of an organ donor. So for children who are born with a diagnosis of anencephaly, whose neurologic outcome will be poor and they will have a short lifespan, but typically all of the other organs have well developed. So the question is it ethically permissible, supportable to support the child who is anencephalic and allow retrieval of organs to be transplanted into other living patients if they have not officially been declared dead because they have not had a circulatory death and they are not in the classic sense neurologically dead. Because to examine a newborn to determine if they, again, qualify as a donor after neurological death determination, it's usually based on exam. Is the child comatose obtunded? Do they have fixed and dilated pupils? Do they have reflexes? Are they apneic? Do they breathe on their own? So EEGs and other imaging studies can help to determine brain death, but it is very difficult, unlike in older and other populations, to determine death from a neurologic cause. But as I alluded to on a past slide, those children with a diagnosis of hypoxic ischemic encephalopathy, they are the children that we can more clearly make a diagnosis of brain death because we are able on exam to truly credibly say that they do not breathe. They do have fixed and dilated pupils, and thus it is a little bit clearer in making that determination. Again, TCH is a large organization, many providers, many trainees across the full arc of medical training. There are some tools that are in place that as an institution helps us all to be more mindful and good stewards as we think about organ tissue donation. And one of them has been through our electronic medical record EPIC system in that we have an end-of-life navigator, which you see a screenshot of before you, which reminds every provider, myself and every provider, whether it's a first-year intern or a professor of pediatrics, if a newborn in the NICU dies, this end-of-life navigator reminds us to all be good stewards of having a conversation with the parents about their child's potential as an organ or tissue donor, and more importantly, being able to contact our OPO because they are truly the expert. Our life gift colleague is the expert who will come to the bedside and review the case and to determine if the child qualifies, whether it be donation after circulatory determination of death or that rare donation after neurologic determination of death. At least this tool in EPIC reminds every provider who pronounces a child, touch bases with LifeGift and our IPO, and let's document that we have been proactive in having the conversation with the family, and then let LifeGift, our expert colleagues, come in and have more conversation with parents. So as we go further in our end-of-life navigator, you can see there is truly a trigger, a clinical trigger, so that we ensure that LifeGift is involved and aware of every death, and to discuss with them how we approach a family about their child being a potential donor, and then leave it to our expert OPO colleagues to come in and take it to the next level and be very specific. We do have a palliative care service called Perinatal Pediatric Advanced Care Team. Again, this works through the fetal center when a fetus is now diagnosed with a life-threatening, life-limiting condition, and the prognosis is poor for outcome. We as a team, we have social worker, we have our nurse, we have child life specialist, we have a doc and a nurse. We work with the family to develop a plan of care, and some families still choose to do all life-sustaining intensive care interventions, and we support that. But for some families, they will choose palliative care, comfort care, and their children will always be with them. After mom delivers, she and her newborn will be in the mother-baby unit in the pavilion, and both will be cared for, and the child will be given comfort care until a natural death, or a child will be discharged to home on home hospice. And that is for some of the families. But for each of these families, we discuss with them as we develop their birth plan, which you'll see an example of one page of, our conversations before the birth of their child, knowing the family has now chosen palliative care, hospice care. We have a conversation about things like autopsy, and moreover, thinking of what are some of the legacy mementos whereby your child can have a lasting meaning, and organ tissue donation is a part of that conversation. And for those families who choose to develop a birth plan for palliative care, if they have opted for organ or tissue donation, that will be reflected in the birth plan so that all providers will know. We do, and I know Schawnte alluded to the fact that some of our families, we've learned through them, at least I have, that there are other opportunities for families to donate and to work with organizations to further medicine, and again, to embrace the legacy of their child impacting medicine and health outcomes for years to come by donating organ or tissue. And we've worked with the IIAM for some of our families. You can see a screenshot of their webpage. They've been around since 2012. We have, as Schawnte said, worked with a few of our families, and their children at the time of their death had some of their organ and tissues donated for furthering research across the full arc. And these families the IIAM will stay in touch with them over years to have them know and to give them feedback about how their children's very generous donation is making a difference as it relates to us learning more about how to be better medical providers and to improve the patient outcome. One of the things before I finish is that there are a lot of so many issues as it relates to the neonate and the unique considerations as it relates to them being an organ or tissue donor. One of the ones, and it's always the elephant in the room I find, is that because we do have such a culturally diverse patient population and our families come from every background, every religious and spiritual and cultural background, who have very differing, divergent ideas about death and the issues surrounding death, especially of a newborn child. So it's a very big challenge to say that as we approach each of our families and meet them where they are, and we approach them about their child dying from a condition, and then, moreover, to discuss whether they would be a proponent of their child being an organ donor, it's something that does add to, again, the unique considerations. So I'll end on that, and here it is, 1:52. I thought, here in Houston at least, that I will bring my discussion to a close and turn it back over to our moderator.
Thank you, Dr. Johnson, and also Schawnte for such a great presentation. Before I turn it back over to Rachel to facilitate the Q&A session, I'd just like to remind everyone that if you do have any questions for either of our presenters, please be sure to use the chat feature. Just as a reminder, it's located at the bottom left-hand corner of your screen. Also, during the Q&A session, I'll have this poll up. For those of you who are listening in a group, please complete the poll and let us know how many people are actually participating in your group. That being said, I'd like to turn it back to Rachel to moderate your questions. Thank you.
Thanks, Deanna, and thank you, Schawnte and Dr. Johnson. We do have a few questions that have come up. So one of those, Schawnte, I'll direct it over toward you. Which transplant centers are routinely importing neonatal en bloc DCD kidneys? If you can go ahead and answer that one.
Sure. Thanks, Rachel. So several that I'm aware of. One of the first is out of Utah in Salt Lake City at the University of Utah. There's also Loyola University Medical Center and University of Chicago, Illinois in Chicago, as well as UC Davis and Cornell in New York.
Okay, great. Second question that we have, and this is probably for both either Schawnte or Dr. Johnson. So babies can often breathe for hours or days post-withdrawal of life-sustaining treatment. Do you use any form of a DCD tool for evaluation, and or do you intubate an anencephalic baby for organ donation?
Well, I can speak a little bit, Diane. Yes, you're right. Babies can breathe for many hours or days after withdrawal, and we do not use a specific tool. Having said that, as you can imagine, babies are still being constantly monitored during that time, and as death becomes more imminent, we can be more in touch with OPO if the family has chosen or want more information about tissue organ donation. And in our practice right now, we do not intubate anencephalic babies for organ donation.
And then Rachel, just to speak to for, I know Texas Children's not, but other hospitals in our service area, they will intubate depending on what the parent's request is at the point in time we're having discussions with them.
Thank you both. And then our third question comes from Emily. Do you have any pamphlets that you provide to high-risk OBGYN offices?
So currently...
Yes, Schawnte, I think that's for you, dear.
Thanks, Karen. So currently, we really rely on the information that we receive from our organizations, but something that we are working on internally is being able to provide that and provide greater education to our hospitals and so that those neonatologists, OBGYNs, to increase awareness, because we often get the phone calls wanting information to be able to give to families when they pose the question. So currently we're relying on the resources that we have in terms of documents from the websites of partners that we're affiliated with.
And even though, Emily, you didn't ask you asked specifically about OB-GYNs, it just reminds me to just again reiterate that the burden is on, for those of us in the NICU taking care of patients, if there is, if you will, an imminent death, to notify the OPO sooner. One of the things I think that happens with us is that we don't notify our OPOs until the baby has been pronounced dead, and there's not adequate time to really reach out to the family to have conversations about potential organ donation.
And Dr. Johnson, this is Schawnte chiming in again. I agree with you, which is the way in the very beginning, the most important I really want to touch base on is like we use those triggers, and I think that sometimes people look at triggers being different in the pediatric environment than for the adult and notifying the procurement organization. But the most important thing is making that call to the OPO so that there's that early linkage and provides the opportunity for evaluation so that we can provide the most accurate information to parents about the opportunity for donation for their child.
Okay, great. There are no other questions in the queue at this time. So Deanna, I'll turn it back over to you since we only have about 2 minutes left.
All right. Well, thank you, Rachel. On behalf of the Alliance, I'd just like to extend a sincere thank you to both of our speakers, Dr. Johnson and Schawnte, as well as Rachel for taking the time to join us today and to share your expertise. We truly are appreciative. And to all of our participants, as always, we thank you for your time, and we thank you for joining us for today's webinar, and we wish you a wonderful rest of your day.